Okay, hello everyone. Thank you for joining this event to talk about HRD testing across different tumors. I think we are starting now, though most likely people are going to join in during the presentation, so I hope you just can bear with it. So really warm welcome to everybody. Thank you for joining us tonight. My name is Lisa. I'm the Regional Medical Manager with Genomics, and I'll be the MC for today. Just a brief sort of announcement that on your chairs there were some survey cards as well as question cards. If you have any questions, please just fill them in and pass to any of our colleagues in the back rows or who are moving around. And at the end of the event, it would be great if you can fill in the survey form and pass to us as well. And now it gives me a big pleasure to really introduce our chairperson as well as one of the speakers, Prof. Lee Soo-chin. She's a known specialist of breast cancer and cancer genetics. She's currently the head of Department of Hemato Oncology, Associate Director of Research, and Senior Consultant in Medical Oncology in the National University Cancer Institute, Singapore. And she's also a research PI and Associate Professor at the Cancer Science Institute of Singapore. We were a warm welcome to Prof. Lee.
Thank you all for coming to this evening's symposium. This is a very nice venue, but it's quite difficult to find, as some of you may have noticed. But anyway, we all are here, and hopefully there may be some other people who will join us. So tonight's symposium is on moving from BRCA to HRD beyond women's cancer. And I think this is increasingly becoming an important topic because as we have seen more and more data coming out telling us that we could use PARP inhibitor for this cancer and that cancer, and then it's getting a little bit confusing on what test to order, and different cancers may have different tests. So today we are very honored to have actually two other distinguished speakers here, Dr. Shahina as well as Professor Michael Friedlander. So we're going to hear about, there's going to be three topics. So first on BRCA testing, and then beyond BRCA testing, does HRD matter? And then I'll end up with actually some clinical case sharing, a real world experience on what testing situation is like. So without further ado, I will introduce the first speaker, who is Dr. Shahina Dawood. And actually, I think she needs no introduction. She's quite well known here in Singapore. So people who have attended APBCS, who have attended iBRCA will actually know her. She's a very good speaker. She's a consultant medical oncologist at Mediclinic City Hospital in Dubai, UAE. She trained in medical oncology at McGill University in Canada. She subspecialized in breast cancer management at the MD Anderson Cancer Center in USA. She has a Master of Public Health degree from the Harvard School of Public Health, and she is very well published. So she's going to tell us today about BRCA testing, old story and new opportunities.
All right. So thank you for the invitation to come and talk about BRCA testing, old stories and new opportunities. Let me tell you what I've learned since I came to Singapore a couple of days ago. So first, the weather is beautiful outside. Two, there are many hotels around here. So that's why I think a lot of your guests have probably gotten lost, or they're stuck at ESMO Asia, which I think has been fantabulous this year. And three, I think we've had an awesome crowd that really wants to learn about something that's very, very important. And I don't know if you came to the PARP talk that we had yesterday at ESMO Asia, but it really was very well attended, really reflecting the fact that a lot of people now want to try and incorporate this into their clinical management because it's become that important. But let's start going back in history. The story begins in the 1990s when Mary Claire King actually first discovered the whole concept of the BRCA gene, which was on the 17q21 chromosome, that was essentially associated with a higher risk of developing a number of BRCA-associated malignancies, such as breast, prostate, pancreatic, and ovarian cancer. And the reason why this detection or testing of BRCA gene mattered in patients who were at these higher risks was because we knew that if you had a mutation in either BRCA1 or BRCA2, you had a higher risk of developing breast cancer and ovarian cancer, and these risks, in fact, increased over time. Now, when I have a patient that has breast cancer, and I don't do screening, but as a medical oncologist, I'm seeing patients who come to my clinic already diagnosed with some malignancy or the other, and if they've got got breast cancer that are young, and I've tested them, and they actually turn out to be positive for a BRCA1 or a BRCA2, I immediately tell them that they're at a 70% lifetime risk of developing cancer of the other breast. They're at a 50% lifetime risk of developing ovarian cancer, which increases exponentially by the time they're aged 40. And you have to put parameters in line or in place to be able to screen these women going forward. So it does become an important tool to be able to screen your patients who are already diagnosed with cancer, as well as you have to be able to counsel them in order to be able to test their family members, because they also have a 50% probability of carrying that gene. And we do realize that since the introduction of the whole concept of BRCA testing, there's been a huge upsurge in terms of testing for BRCA. We also know that the models that we have here, such as the BRCA Pro model, that it's a simple program online. You have a person that comes into your clinic and you try and compute their risk of, or their probability of actually having the BRCA mutation. And you can see where testing is not being recommended. So I think the mic is working now. It wasn't working before, right? So, and in people where the testing is not recommended, studies have actually shown that you could actually miss almost 28% of those people carrying the gene. So we don't have a perfect model that can actually accurately predict for who does or does not have that particular BRCA mutation. Why is BRCA mutation important for medical oncologists? It's because we now understand that patients with BRCA mutations could potentially actually benefit from using a PARP inhibitor. So you have a target with a drug that can attack that particular target. Why is that so? So this slide basically gives you a very quick mechanism of action. You have your DNA that could develop single-strand breaks, and in order to repair the single-strand breaks, you need base excision repair, and for that, you need the PARP enzyme. You can also have double-strand breaks in your DNA, and that is usually repaired by homologous recombination. And we know in patients who've got a BRCA mutation, this doesn't exist. It actually is deficient in these patients. So in patients who have a BRCA mutation, where they do have a non-functioning homologous recombination mechanism, you could actually treat them with a PARP inhibitor, so you're inhibiting that PARP enzyme, and as a result, that cancer cell will eventually die. And so as a result of this hypothesis, PARP inhibitors have been extensively investigated. This was one of the first papers that came out way back in the early 2000s, where we saw preclinically that if you attacked a cancer cell line that was BRCA deficient and you attacked it with a PARP inhibitor, you could see very nicely that these tumors actually responded very, very well. And this was a phase 1 clinical trial that actually looked at taking a variety of different patients with BRCA mutation positive disease. This was a patient with ovarian cancer that was treated with a PARP inhibitor, and you can see this was at baseline. At 4 months, the tumor had decreased in size. This was another patient that was also an ovarian cancer patient at baseline, and after being treated with a PARP inhibitor, you can see it's almost disappeared. So as such, we then went on to test PARP inhibitors in a number of different malignancies. And the 3 most important malignancies that we'll discuss today includes ovarian cancer, pancreatic cancer, and breast cancer. We're also going to talk about prostate cancer, but a little later during the talk. Now, why was it important to actually look at PARP inhibitors in patients with ovarian cancers? Well, almost 13% of patients with ovarian cancers, in fact, have BRCA mutations. And not only do they have BRCA mutations, they have a whole spectrum of different mutations that attack the homologous recombination pathway. And these patients almost constitute almost about 50% of patients with ovarian cancer. Now, there's a lot of data out there that's looking at patients with ovarian cancer and treating them with PARP inhibitors, but the most important trial in my mind is the SOLO-1 trial. This is the only trial I'm actually going to show you for ovarian cancer, and I'm going to look at some of the other data later on. But the SOLO-1 trial took patients with ovarian cancer who had BRCA mutation positive disease, either BRCA1 or BRCA2, these patients had either a partial or complete response to their chemotherapy in the induction phase, and then in the maintenance phase they were randomized to either receive olaparib or they were to receive placebo. And you can see spectacular Kaplan-Meier curves, very early separation of the Kaplan-Meier curves, which translated into a median progression-free survival of 13.8 months in the placebo arm, not reached in the olaparib arm, translating into an almost 70% reduction in the risk of progression of disease. And you can see in the subgroup analysis, every single cohort of patient actually benefited from receiving olaparib, including those hard to treat high-risk groups, such as those that had partial response, or those that had residual disease at post debulking of their cancer. So again, all subgroups actually benefited. What about breast cancer? In breast cancer, there was a proof of concept trial that was published way back in 2010 by Andrew Tutt's group. And what they essentially showed was that in patients with BRCA1 or BRCA2 mutations, if you subjected them, these were heavily pretreated patients, if you subjected them to a PARP inhibitor, more than 3 lines of therapy failure, you did have some nice responses. This was one example of a patient with bilateral IBC triple negative with a BRCA1 mutation. Look at that tumor. It was really horrible. Pre-PARP inhibitor and post-PARP inhibitor, a nice response. This was a patient with the same patient with lung metastases as well. And you can see 18 months on, the patient is still responding to that PARP inhibitor. So this spurred 2 important clinical trials that actually looked at PARP inhibitors in patients with BRCA1 or BRCA2 germline mutations, in patients who had been pretreated with either first-line chemotherapy, or if they were triple neg, or endocrine therapy post their having progressed on multiple lines of endocrine therapy if they had hormone receptor positive or plus HER2 negative metastatic breast cancer. And you can see whether you looked at the Olympiad trial that looked at olaparib versus physician choice of chemotherapy, or the EMBRACA trial that looked at talazoparib versus physician choice of chemotherapy, you can see there's a nice separation in the Kaplan-Meier curves with about a 4-month improvement in the progression-free survival. So again, 2 important positive trials. What about pancreatic cancer? Now, all of you know that patients with pancreatic cancers, metastatic, have abysmal outcomes. Their prognosis is really, really bad, with an overall survival ranging from anywhere from 6 to 12 months, even in the best setting. But now we've come to learn that there are targets that one could potentially use in patients with pancreatic cancer. Very interesting poster that was presented at ASCO this year that took 1,676 patients with advanced metastatic pancreatic cancer, tested them in a multi-gene panel for 25 to 29 cancer susceptibility genes, and what they found was about 12.6% of these patients had a pathogenic variant, and irrespective of their age and diagnosis, family history, or history of other cancers. And what you saw was that almost 85% of these patients had a pathogenic variant either in their BRCA, ATM, PALB2, Lynch syndrome genes, or if you're looking at that pie chart, basically in this part of the curves. And what they also showed that the pathogenic variant rate went up to almost 15% if you had more than 2 family members who had a history of having had cancer in the past. Now, was this the only biomarker that could potentially be present in pancreatic cancer? Actually, that's not entirely true. There's a whole potential different plethora of biomarkers that one can see in pancreatic cancers, with almost 24% of these patients with pancreatic cancer having some sort of deficiency in their DDR pathway. Now, why am I also putting this when I'm supposed to be only talking about BRCA mutations? Well, in pancreatic cancers, this becomes exceptionally important, because if you find a target and you're able to appropriately treat that target in a patient with metastatic pancreatic cancer, you may be able to improve survival. And I love this slide that I've put together because it actually compares it to non-small cell lung cancer. You know patients with non-small cell lung cancer, if you have targeted therapy, that means you're matching therapy, you know that they're going to do very, very well. Look at these curves. This was a study that was presented at ASCO this year, and you can see patients with pancreatic cancers that are matched for their therapy actually are now beginning to do much, much better. A median overall survival of 2.58 years when you're matched, versus if you're not matched, where you have a survival of anywhere between 1 to 1.5 years. Abysmal prognostic outcome in patients with pancreatic cancer, but if you match them, they're now beginning to do well. And you can see on this slide, there's so many different actionable mutations that one can think about in patients with pancreatic cancers. And we know that 17 to 48% of pancreatic cancers will actually harbor these actionable findings. But more importantly, although we don't have prospective randomized clinical trials for all these targets, because this is such a hard to treat tumor with such bad prognostic outcome, NCCN in 2019 has now actually written, it's there in their guideline, which is helping a lot of patients actually get insurance approval, where germline testing is recommended for any patient with confirmed pancreatic cancer using not only BRCA1, BRCA2 testing, but using a comprehensive gene panel for hereditary syndromes. And they also recommend that tumor somatic gene profiling is now recommended for patients with locally advanced metastatic disease who are candidates for anti-cancer therapy to identify uncommon but actionable mutations. They're actually expanding this cohort. These two statements are actually not there for the majority of cancers in NCCN, but they've put it there for pancreatic cancers. And the reason why this is so important, it's a hard to treat tumor, which makes the POLO study that much more important. And the POLO study was a study that actually was recently came out. It was a cohort of patients with metastatic advanced pancreatic cancers who'd responded to chemotherapy in the form of FOLFIRINOX, and they were randomized to either placebo or olaparib if they had a BRCA1, BRCA2 mutation. And you can see a nice separation in the Kaplan-Meier curves. We don't tend to see this. Now, I get a lot of comments whenever I give a talk like this that, look, it's very modest in terms of that separation of the Kaplan-Meier curves, but we don't see this in pancreatic cancers in general. And you can now see a targeted therapy in the maintenance scheme where you're now beginning to see the separation and an improvement in progression-free survival. And if you look at that subgroup analysis, the majority of patients are now benefiting from maintenance olaparib. So if you put it all together, I've shown you data for the use of PARP inhibitors when you have a germline BRCA1, BRCA2 mutation in breast cancer, in ovarian cancer, in pancreatic cancers. You can see the progression-free survival across the board has improved. You see the majority, the best benefit you're actually seeing in ovarian cancer, but also importantly in breast and pancreatic cancer. But the story doesn't stop here. I think with all that I've told you, we probably now have more questions than we have answers. And I'm going to try and look at some of those questions that have come up as a result of having such spectacular data. One of the first questions that's actually come up, and this is a very long-winded question that's up there, so I'm going to sort of summarize it. How many patients are you actually going to get for germline positive BRCA mutations if you sent those patients based on clinical criteria that's been recommended by NCCN? Can you get more patients if you were to expand that cohort beyond the NCCN clinical guidelines or the ASCO clinical guidelines that are there in terms of who to test for germline testing? So this came out of the Memorial Sloan Kettering group, in which the oncologists sent out about 1,040 patients for germline testing, irrespective of whether they conform to guidelines or not. What the authors showed was that 17.5% of patients had more than one actionable germline pathogenic mutation that was identified. But more importantly, 9.7% of patients that were detected to have some form of germline mutation would not have conformed to the clinical guidelines if the oncologist didn't feel that, I need to send it off irrespective of those clinical guidelines. And as a result, you had an additional 3.7% of patients that could be suitably treated with a particular target. So you're expanding the cohort of patients if you were not to conform to those guidelines, but you have, other characteristics that you wanted to be able to send your patients for germline testing. The second important question that comes up is BRCA1, BRCA2 mutation in fact an agnostic for PARP inhibitors? Well, the simple answer to that question is actually no, but let me give you the data for that. We know that about 4.9% of patients have germline pathogenic or somatic mutation. This comes from a cohort, again, from Memorial, where they tried to actually answer this question. And so in this cohort, about 4.9% of patients had either germline pathogenic or somatic loss of function mutations in the BRCA1, BRCA gene. And you can see that the loss of heterozygosity was higher in BRCA-associated tumors like pancreatic, ovarian, prostate, and breast compared to those that were BRCA associated. You also saw higher degrees of homologous recombination deficiencies in BRCA associated tumors compared to non-BRCA associated tumors. And you also saw that non-BRCA associated tumors were associated with somatic loss of germline pathogenic alleles. So collectively, these data suggest that there's different tumor lineages vary in their phenotypic susceptibility to a BRCA1, BRCA2 defect. Now, in terms of benefit to PARP inhibitors, does it matter if you have a BRCA-associated tumor versus a BRCA non-associated tumor? And I already told you from a preclinical perspective, yes, there are differences. But from a clinical perspective, as a medical oncologist, I now need to know if I'm going to give a PARP inhibitor to a patient who says has lung cancer and has a BRCA1, BRCA2 mutation. Is it going to work? Simple answer, you can see these Kaplan-Meier curves. If you have a BRCA-associated tumor and you're subjected to a PARP inhibitor, you do much better than if you have a BRCA-associated wild-type tumor. But if you have a BRCA non-associated tumor, such as, say, a cholangiocarcinoma or a lung cancer or a kidney cancer, and you try and treat with a PARP inhibitor, no difference between the BRCA mutated and the BRCA wild-type. So overall, mutant BRCA is an indispensable founding agent for some tumors, not all tumors. Particularly, it's more important in patients with pancreatic, prostate, ovarian, and breast cancer. These are the BRCA-associated tumors. Now, the next question is, in BRCA-associated tumor, does it matter if you have either a somatic versus a germline mutation in terms of whether you're susceptible to a PARP inhibitor? Well, why is this question important? It's important because we do have these BRCA-associated tumors that have also somatic mutations, and more so when you look at patients with prostate cancer, they have very similar, actually, somatic and germline mutation incidences. So this is a very, very important question. And when you're looking at susceptibility to PARP inhibitors, you can see from this Kaplan-Meier curve, if you have a BRCA-associated tumor and that patient has either a germline mutation or a somatic mutation, you are going to benefit from a PARP inhibitor versus if you have a BRCA wild-type disease. So it doesn't matter whether you have a somatic or a germline mutation, so long as it's a BRCA-associated disease, you will benefit from a PARP inhibitor. The next question is, in a BRCA-associated tumor, is PARP inhibitor therapy different based on the zygosity of BRCA? And the simple answer to that is no, it doesn't actually matter. And you can see here clinical benefit in the heterozygous versus biallelic BRCA1, BRCA2 mutation. You can see it's the same. And if you substratify based on whether someone has a somatic or a germline mutation, you can see all four classes of BRCA mutant patients achieve significantly greater clinical benefit to a PARP inhibitor therapy than do patients with wild type. So it doesn't matter whether based on zygosity whether you're going to respond or not. These patients do respond to a PARP inhibitor. The next question is, can we expand the cohorts of patients that could benefit from PARP inhibitors, where it may not only be about BRCA? So the first question, and I've put an algorithm here because I think there are different strategies that have been adopted to try and expand the cohort of patients that could potentially benefit from a PARP inhibitor. And the first is expanding identification of pathogenic BRCA1, BRCA2 mutations, maybe by including somatic mutations. I've already told you that it actually responds to PARP inhibitors, but more importantly, accurately classifying a VUS. And I love using this example where I've had 3 sisters all coming to the clinic to see me because all 3 sisters have, in fact, cancer. The first sister was patient number 1. She's in her 40s, diagnosed with breast cancer at age 25, treated and recurred at age 45. This was the BRCA VUS that she had. The second sister came to me at age 50 with stage 4 de novo breast cancer. She'd received multiple lines of therapy. I tested her. She had the same BRCA VUS. The third patient was also a sister. She came in her 40s. She had breast cancer at age 30. She came to me in her 40s. I, for some reason, did a CEA value on her. I found it elevated. I did a scan, and she has colon cancer now that was metastatic to her liver. And I tested her, and she has the same BRCA VUS. Now, when these three sisters actually came to see me, I didn't know they were sisters until I tested them, and the husband of this patient came and told me, do you know that you're treating the other two sisters? And then I compared and I said, my God, they've all got the same BRCA VUS. Would you use a PARP inhibitor in a patient that has a BRCA VUS that is so, for me, this is a pathogenic BRCA mutation. I submitted it to ClinVar, and they refused to reclassify it. So I submitted it to my humble MDT, and they said, please treat it with a PARP inhibitor. And I treated actually this patient with a PARP inhibitor. I treated that patient with olaparib. She's heavily pretreated. She's now 2 years out CR with a PARP inhibitor with olaparib. So in my mind, this is a pathogenic mutation. It also tends to tell you that you need to be discussing these cases in an MDT, because you might find VUSs like this that you can reclassify as a pathogenic mutation. And of course, I've just told you somatic mutations, it does work, PARP inhibitors. This comes from the Ariel 3 trial, where you can see that even patients with somatic mutations, if you gave them a PARP inhibitor who have ovarian cancer, it responds. Then we could also be identifying beyond germline BRCA1, BRCA2, a concept known as identification of HRD nests. These are tumors without germline BRCA1, BRCA2, but they show homologous recombination deficiencies. Maybe we need to determine an HRD phenotype beyond defects in the BRCA pathway, including patients with other mutations for DNA damage. In the realm of pancreatic cancers, this hasn't been explored yet with PARP inhibitors, but we had some preliminary data actually again from Memorial that took patients who weren't treated with PARP inhibitors, but they did reclassify them based on their HRD. And you can see that if you had HRD, irrespective of whether you had a BRCA1 or BRCA2 mutation, you did have better prognostic outcome, especially if you were treated with a platinum. In ovarian cancer, we know there are 3 distinct groups of patients with ovarian cancers: those with germline BRCA mutation or somatic BRCA mutation, those with an HRD defect but BRCA wild type, and then you have the HR proficient group of patients. Why would a patient with ovarian cancer BRCA wild type respond to a PARP inhibitor? Well, in the BRCA wild type, I think there are 2 subcategories: those where you have BRCA wild type HRD defect, that means they have loss of heterozygosity, while those BRCA wild type patients where they don't have loss of heterozygosity and will most likely have variations in their PARP sensitivity. We know that in patients with germline mutations who have ovarian cancer, perhaps only giving, and that comes from Solo 1 and the PRIMA trial, that only giving a PARP inhibitor is enough. You may not need to add bevacizumab, as the Paolo 1 study has actually shown. So in my opinion, at least when you're testing, it's important to still test for BRCA, because if you're BRCA positive, you may not need to give all these additional therapies that are being explored. But we also know that in patients with ovarian cancer, if they have a BRCA mutation, they have the best PFSs. But if they have HRD BRCA wild type, you have impressive PFSs, but again, slightly less. And if you are HR proficient, you still are benefiting somewhat, but not as much. So sensitivities to your PARP inhibitors will vary based on your HRD status. We also know that HRD and BRCA status will help you choose your therapy, and I've sort of given the summary of the Solo 1, Paolo 1, and the PRIMA trial, and compared it to the GOG 218 study that looked at only bevacizumab without a PARP inhibitor in these patients. And just to summarize, and if you look at these hazard ratios, if you're BRCA mutation positive, PARP inhibitors should be enough. I've just told you that. If you're BRCA wild type, but you're HRD positive, again, look at those impressive hazard ratios when you give a PARP inhibitor versus if you give bevacizumab alone. I think, again, PARP inhibitors should be considered the standard. But if you're HR proficient, you may actually want to consider PARP alone or PARP plus Bev or Bev alone. So it's a very gray zone area, and this is something I think the next speaker is actually going to be expanding on and talking about HRD and the HR proficient subgroup. But why would a PARP inhibitor actually work in a PARP, in an HRP or HR proficient cohort. My explanation, and this is just a snapshot view, you're going to hear about it later on in much more detail. My idea is that there is no perhaps one cutoff score for homologous recombination deficiency. We know all the clinical trials have actually used cutoffs of 42 for that score, but there was a retrospective study, it was called that looked at data from study 19, that was a cohort of ovarian cancer patients treated with olaparib, where they looked at differences if you looked at a score of less than 33 versus less than 42, and what they essentially showed was that if you changed your score, you could have a larger group of patients that in fact benefited from PARP inhibitors. So again, I don't think the story is that simple, and that's going to be clarified later on because you need hours to discuss this. But could this be a method of refining that HR proficient subgroup that could benefit from PARP inhibitors? Now let's expand that realm of HRDness. And remember I told you one of the other BRCA-associated tumors is prostate cancer. Why didn't I talk about it earlier on when I looked at only germline BRCA1, BRCA2? Because in the realm of prostate, it's not only about BRCA1, BRCA2 testing, but really expanding to other biomarkers. And one of the first studies that actually came out was from Mateo's group. It was published in the New England Journal in 2012, where 49 patients, heavily pretreated prostate cancer patients, were subjected to single agent olaparib, and what they found was that the 7 patients with BRCA2 mutations actually responded to the treatment. But not only them, you can see from this plot over here, there were other biomarkers within that class of patients who had heritable genes that also responded. So what they did was they put it all together and they developed a biomarker signature, and they found that patients who are biomarker positive and treated with olaparib did very well versus those who were biomarker negative. And this was both in terms of progression-free survival and overall survival. So treatment with PARP inhibitor olaparib in patients who had defects in either the germline or somatic DNA repair genes, so not only BRCA1, BRCA2, led to high response rates, improvements in progression-free survival, and improvement in overall survival. And this is what led to the PROfound study. The PROfound study was a phase 3 clinical trial that took patients with prostate cancers who had progressed on abiraterone or enzalutamide, and they were basically castrate-resistant metastatic prostate cancer patients who had some form of defect in their homologous recombination repair gene pathway. And what they did was they randomized these patients to either receiving olaparib or receiving enzalutamide or abiraterone. And you can see in terms of progression-free survival in the cohort of patients who had a BRCA1, BRCA2 or ATM mutation, again they had a very nice separation in the Kaplan-Meier curves, improvement in progression-free survival. But it was not only restricted to this. In an exploratory analysis, they looked at the PFS across the HRR genes alterations. They found the biggest benefit was actually amongst patients with BRCA2 mutations, another big benefit in patients with RAD51 mutations, not so much benefit in patients with BRCA1 mutations. But again, this was exploratory. And what I personally believe in prostate cancer patients, we need to be looking at all these genes in the HRR pathway, not only BRCA1, BRCA2. What about identification of PARPness? What is PARPness? Well, PARPness are cancers that lack mutations in the HRR pathway and do not typically display an HRDness, but they still have some sensitivity to PARP inhibitors. Now, why did I put this in? This is just for completeness sake. It doesn't actually pertain to testing anyone. But the reason why I put this in was because it does pertain to some malignancies like small cell lung cancer, where you can actually target with a PARP inhibitor, although they don't have a defect in their DDR pathway. Why? Because they are actually very, very dependent on an intact stable DDR pathway. And what you see in small cell lung cancer patients, they actually have loss of RB1 and they have loss of TP53, which can sometimes cause instability. And when that instability happens, by adding a PARP inhibitor, they may actually become sensitive to that pathway. And you can see this was a very small trial that looked at a combination of olaparib and temozolomide in relapsed small cell lung cancer. And these were patients who were heavily pretreated, overall response rate of 41% and overall survival of 8.5 5 months, and you can see there was no difference in overall survival by platinum sensitivity. So it didn't really matter if there were mutations in that HRR pathway or not. So even tumor lacking HRDness could be potential candidates for PARP inhibitors, but this is just something that I put there as food for thought, but something that we need to think about. I think identifying resistant mechanisms to PARP inhibitors is just as important as identifying patients who will be sensitive to PARP inhibitors. This becomes particularly true in patients with ovarian cancers and patients with prostate cancers, pancreatic cancers, where you may think about re-challenging these patients with PARP inhibitors in the future, or even after they've been treated with a platinum, should they be even treated with a PARP inhibitor, because they may have already developed a resistance mechanism to that PARP inhibitor. We have several mechanisms that are being investigated for PARP inhibitors, including drug avoidance by pumping these drugs out of the cell through a membrane protein, restoration of the fork protection by inactivation of nuclease enzymes, remutating the original BRCA mutation to restore the functions of the BRCA proteins, and of course restoration of homologous recombination repair. Now, this was just a case study that came out a couple of years ago that I think very nicely illustrates the BRCA2 reversion mutation that's associated with an acquired resistance. This is a patient with breast cancer that was treated with multiple lines of therapy, and then she was found on a tissue biopsy to actually have a BRCA2 mutation, and she was then eventually treated with olaparib over here. She had about a 6-month median progression-free survival, at which time she progressed, and they added olaparib to chemotherapy, and this patient continued to progress, and that's where they tested and they found that she had in fact developed a BRCA reversion mutation. I also think in the realm of ovarian cancer, this becomes more important as we use maintenance therapy for PARP inhibitors in ovarian cancers. Once you've completed your maintenance therapy, if that patient recurs, can you re-challenge with a PARP inhibitor? Perhaps you need to test those patients for BRCA reversion mutations, because if they have a BRCA reversion mutation, giving a PARP inhibitor is not going to work in that particular patient. So again, it's going to become something that we're going to need to test in the future. And finally, a snapshot view of what I think the future is going to be. It's going to be combination strategies with BRCA, with PARP inhibitors, because we know not all patients with BRCA1 mutant cancers will respond to PARP inhibitors. We know that drug resistance will eventually develop, and somehow we need to delay that. We want to maybe increase the response rates and those durability of responses. So we're going to look at PARP inhibitors with molecularly targeted therapies like BEV, like MEK inhibitors, PI3 kinase inhibitors. In fact, we've had some nice preliminary data looking at olaparib and alpelisib in patients with breast cancer, wild-type BRCA, where they've seen some nice responses, even better than when you give alpelisib with endocrine therapy. We've also seen in patients with prostate cancer the combination of olaparib plus abiraterone, and we've seen some nice data looking at, irrespective of whether you're selecting them for their BRCA status or not, there seems to be some nice responses there. We're also going to look at PARP inhibitors with other DDR inhibitors, so it's going to be important for us to also look at those and test those targets in the future. And of course, now this is upcoming, I won't berate the point, we're going to look more and more at the combination of PARP inhibitors and immune checkpoint inhibitors. It's literally becoming even more important, because patients with BRCA1 and BRCA2 mutations actually have, most of them, high tumor mutational burdens, where you're going to really think about using those immune checkpoint inhibitors where you know you're going to have maybe a higher response rate. So my conclusion slide, there is no doubt that BRCA is now an important marker to allow for identification of patients at high risk of developing malignancies. That's your screening cohort. But what about for the medical oncologist? We now know that BRCA is an established biomarker that identifies patients with BRCA-associated tumors that will likely respond to PARP inhibitors. In my opinion, all patients with BRCA-associated tumors should be tested for BRCA, and my personal opinion, it shouldn't only be BRCA. I think you need to do the expanded panel to look at all those genes, because we are now going to be using PARP inhibitors beyond BRCA. For the present time, BRCA mutation cannot be considered as an agnostic marker. I showed you the data for that. And our current focus should be to expand cohorts of patients with BRCA-associated tumors who could benefit from a PARP inhibitor, including identification of HRD nests, and perhaps also doing those combination strategies that I was talking about. Going forward, it'll be important to identify resistant mechanisms to PARP inhibitors and identify methods to overcome them. Thank you very much.
Questions to the end, but actually Dr. Shahina has to leave because she has a flight to catch. So are there any questions for her talk before she leaves? So I have a question actually about this is interesting family with the three sisters with the VUS, and I agree with you that if you have three affected family members and who actually all are affected and they actually carry the same variant, it does make it a strong case to reclassify. So did you actually communicate with the lab? Because sometimes through the lab it might be a, okay, so
They still refuse to reclassify it, and I think it's just they've got their own mechanism by which they reclassify. But really the point that I was trying to make, like you said, that if it's running in a family and all of them have cancers, you really need to think about the fact that they're pathogenic. That's number one, and that PARP inhibitors could work. But I also think that it also depends on the test that you're doing, because some tests actually classify a high rate of VUSs and some actually classify low rate. I think it also depends on the type. And I'm not a technical person for that, but I think being in Asia, now we're here in ESMO Asia, being in Asia, all the data is actually coming from a Caucasian cohort. We don't have a lot of data in our part of the world to accurately classify this data, including the Middle Eastern patients. And I've always advocated that perhaps we need to pool our data together and come up with our own, classification system, because I think we're very different from the Caucasian cohort. But I'd love to hear your thoughts on that.
Yeah, so I agree with you that it all depends on the population, but as that population gets tested more, then you'll find that the VUS rate will go down. Okay, so thank you very much. So, thank you. Oh, she has a question. Yeah.
So in early breast cancer, when you after you did mastectomy, and then you found that the patient has BRCA positive, germline BRCA positive, are you giving the adjuvant of the BRCA?
So the Olympiad and the AMBRACA trials were only for patients with metastatic disease, not for early stage disease. However, there is currently an ongoing trial right now that's looking at, after you've treated your patient appropriately with chemotherapy, surgery, radiation therapy, whatever is the standard for that particular patient, to maintain them on a PARP inhibitor. But that's still in clinical trial. I wouldn't advocate it outside the realms of a clinical trial right now.
Thank you very much. So thank you, Shahina. I'm going to introduce the next speaker, who is Dr. Michael Friedlander. He's a professor of medicine at the University of New South Wales and director of medical oncology at the Prince of Wales Cancer Centre in Sydney. He's an internationally recognized key opinion leader on gynecological and breast cancers, and he is actually instrumental in setting up the first hereditary cancer in Australia. So he is involved in a number of key PARP inhibitor trials and has published extensively. So today he's going to tell us about beyond BRCA testing. Does HRD matter?
Thank you very much. It's a great honor to be here, and I will discuss beyond BRCA, and obviously you've had a fantastic introduction. I'm not too sure I can add much more to what's been said, but I will perhaps embellish or expand on some of the points that have been raised. So the topic I was asked to address was beyond BRCA testing, does HRD matter? And the answer is yes, it does matter. And what I'm going to talk about today is a number of topics, and I'm going to talk about how do we identify beyond BRCA testing patients who are likely to benefit from a PARP inhibitor. I'm going to touch on briefly the elusive definition of platinum sensitivity and platinum resistance, because this impacts significantly on our practice, and those definitions actually make a difference. And I think if we use them sensibly, we can identify potentially identify patients with HRD, because platinum sensitivity, in fact, is probably a very good marker of HRD. I spent a bit of time talking about the methodology and the methods that are currently available to assess HRD, And then I'm going to discuss some of the trials. Many of them you've actually heard of already, but I'll spend a bit of time on them, and we'll talk about not specifically BRCA, but how HRD impacts on response. And it's not simply looking at hazard ratios, but looking at some of the nuances in those clinical trials. And then I'll touch on a few other things. So predicting PARP sensitivity. Well, BRCA mutations, germline and somatic trump everything. So that they really are the most important, but followed not too far behind are by HRD mutations, and then a number of clinical factors, which all kind of are interrelated because platinum sensitivity, the number of lines of prior therapy, and histology. And I'm focusing mainly on ovarian cancer, but I'll touch on some of the others in a moment. So those are all important factors. So why is HRD important? Well, the previous speaker has gone into that in great detail, but it's the fundamental basis behind the mechanism of how PARP inhibitors function, as well as indeed how platinum actually works. And BRCA mutations are the prime example of HRD, exquisite sensitivity to PARP inhibition, as well as to platinum-based chemotherapy and anthracyclines, as in fact in any alkylating agents. But we know that PARP inhibitors have activity in BRCA wild type and there are many other mechanisms for HR deficiency. And we're going to talk a bit about that in ovarian, breast, and pancreas. But most mature data is on ovarian cancer. Now, you saw the slide, and I won't belabor it, apart from just stressing that about 50% of high-grade serous cancers harbor deficiency in homologous recombination. And that's in contrast to about 40% of triple-negative breast cancers, and in fact about 13% of triple-negative breast cancers also have a BRCA mutation. So there's a high proportion of patients with high-grade serous cancers who have these deficiencies. And one of the problems is in the clinical trials that have been designed so far, we have not used these criteria to stratify. For example, in all the frontline trials, we've used so-called response to platinum. But that's in many respects a misnomer. Because in patients with advanced stage ovarian cancer who've had upfront surgery and either have no macroscopic disease or very small volume disease, it's very, very difficult to measure response. So to assume that because a patient has no evidence of disease at the completion of treatment, to assume that that actually equates with platinum sensitivity is naive. And that probably explains why not all patients respond as well as you would expect who've so-called incomplete response to platinum-based therapy. Because if we could select out the subgroup who have homologous recombination deficiency, I think we'll see even better results. But at the moment, we really can't do that. Now, the other question, of course, that I think has been briefly touched on is, are all these mutations in the homologous recombination repair genes created equal? Do they all predict for response? And the answer is no, they are not all created equal. There's some that are tend to be associated with a much higher response rate than others. Now, these are a couple of studies that just represent the frequency of somatic gene changes that are seen in ovarian cancers, and they range from about 8 to 20%. The majority being BRCA1 and BRCA2, but a smattering of RAD51, PALB2, ATM, etc. And this is a really neat study from GOG 218, where they managed to go back and look at about just over 1,000, almost 1,200 patients who were enrolled in this trial, which is looking at the addition of bevacizumab to carboplatin and cisplatin, carboplatin and paclitaxel. I won't go through the trial design because that's not that important, but I think what is important is that they managed to find that 25% of these patients had mutations in the HR pathway. Majority, as you would expect, were BRCA1 and BRCA2, with about 6% in other homologous recombination pathway genes. And you can see that BRCA2 patients were the ones that did particularly well, but there wasn't much difference between BRCA1 and the other HR genes. So there are multiple potential mechanisms for HRD beyond BRCA1 and BRCA2. There are mutations in many other HR genes. There's genomic scars. There's promoter methylation in BRCA1, for example. There are other mechanisms. But the net effect is impaired DNA repair and genomic instability, which equates with PARP sensitivity and platinum sensitivity. So they all tend to hone in on the same pathway. So the challenge before us, and clinically, is to identify patients with BRCA1 and 2 wild-type tumours with alterations in this pathway who will benefit from PARP inhibitors and possibly from platinum-based chemotherapy as well. And there are a number of ways we can potentially do this. We can do this by looking at germline mutations. We can look at somatic mutations of the HR genes that I just showed you a few moments ago. Functional assays, I think, probably are going to be the key, but at the moment really not really that practical. But I think in time we'll probably see functional assays. And then there's obviously genomic scars and mutational signatures. Now, when you look at the various definitions and the panels that are used for HRR genes, you see there's significant variability. In fact, there's no university-defined gene list. They're all different, and therefore they're all going to impact on what you find in particular patients. And I don't think we're there yet in terms of identifying what the ideal or optimal panel is, although apart from recognizing that they are important. But which ones are important, which ones should we be testing for, I think that's still a work in progress. We've learned quite a lot, I think, from going back and looking at some earlier studies. And study 19 was really it's a really important trial because it sort of set the ball in motion. Everything happened after study 19 because this was the first study that was demonstrated a potential advantage or benefit of olaparib in patients with platinum-sensitive recurrent ovarian cancer in terms of the progression-free survival, and that was independent of BRCA. And about 22% of patients had BRCA wild type, and they had a number of mutations in cancer repair genes. But what is important as well, that if you look at the hazard ratio, and the numbers of patients are quite small, but these were patients who had BRCA wild type, but mutations in the HRR pathway, and you can see that the hazard ratio for PFS was 0.21, which is not that different from the BRCA mutant subpopulation. So the challenge really is identifying who those people are and using panels that'll pick them up. And as the previous speaker just told us, and I won't belabor this, that there's HRR mutations in not only ovarian cancer, but in breast cancer and pancreatic and prostate cancer, but that's just been mentioned earlier, so I'm going to move on. So the test that's been used predominantly in the frontline trials, that's in PRIMA and PALO and VELIA, were Myriad My Choice. So that seems to be the most popular test at the moment, and this uses 3 factors to determine a score: loss of heterozygosity, telomeric imbalance, and large-scale transitions. And the score is defined as greater than 42 or BRCA mutation, and about 50% of high-grade serous cancers are HRD positive based on the Myriad My Choice assay. Now, one of the real big problems with this assay and this test is that it's hardwired. It doesn't change. So if you've got a reversion mutation, or you're resistant to a PARP inhibitor, you're resistant to platinum, you're still going to be HRD positive. So this is the really big problem using this test. And that's why we see such variability depending on the populations of patients treated. So if you look at, and we'll come to that in a little while, if you look at patients who've been heavily pretreated and had multiple lines, they're still HRD positive, and they may have a modest benefit from a PARP inhibitor or for platinum, despite the fact that they seem to have a high score. So we can't simply rely on the score. I think other clinical factors have to be taken into consideration. in terms of how many lines of treatment has that patient had, have they progressed on platinum. All these factors are important beyond simply looking at a number in the score. And as the previous speaker also alluded to, where does that 42 come from? 42 was a figure that Myriad selected as was a threshold for the 95th percentile of HRD scores observed in tumours with BRCA1 and 2 deficiency. It was not based on any clinical outcome or any response data. And if you go back and look at the study 19, which was an exploratory analysis, and if you used an HRD score of greater than 33, and that was 185 patients, you can see the hazard ratio was 0.25. So arguably, it would be more sensible to use a lower cutoff, such as 33, and it'd be very interesting to see if the companies that have done and sponsored the trials that we've all heard about, if they went back and looked at that, could we actually then separate a population of patients who definitely are not going to benefit from a PARP inhibitor, and that if that happens, that remains to be tested. Having said that, if you look at the studies, Velia did use a cutoff of 33. The others used 42. We've seen this as well, and I won't belabor it, but the other assay is the Foundation Medicine T5 assay, which calculates the percentage of genomic loss of heterozygosity. And initially they used a pre-specified cutoff of about 14% to define loss of heterozygosity, and reanalysis suggested a 16% cutoff was a better discrimination, and in fact 16% was the cutoff that was used in Aerial 3, and I'm going to talk a bit more about Aerial 3 in a few moments. But essentially those are the two tests that have been used in all the trials to date, and I think Myriad at the moment probably has the runs on the board and is used more commonly. Now, what if we then drill down and focus on HRD? I'm not talking about BRCA now, but it's HRD and benefit from PARP inhibitors. And if you look really right across the board, whether it's Aerial 2, Aerial 3, NOVA, or the first-line studies, or even the fourth-line studies such as Quadra, you see consistently that an HRD population do appear to benefit more than the HR proficient. And we'll go through that in more detail, each study one by one. This is a recent analysis that was actually well worth reading. It was published very, very recently. And it looks at many things. I've just showed you here the HRD in the wild-type population. You can see clearly in the various studies in the platinum-sensitive space, HRD makes a difference. And I think it makes a difference depending on how platinum-sensitive the patients are. Because platinum sensitivity, per se, is a really good marker of HRD. And if a patient has ovarian cancer and she relapses 2 years or 3 years or 4 years later, you can be 100% certain, or pretty close to it, that she's got a tumor that has an HR deficiency, irrespective of what your score actually shows. And one of the things that none of these studies have actually drilled down on, I think to any great extent, is looking at the platinum-free interval. And that comes in a few moments to how we define platinum sensitivity. But if you look at the platinum-free interval, and I'm talking about now by RECIST, not by CA125, I think you can actually identify a subgroup of patients who will respond very well. And this is probably one of the reasons why HRD populations seem to do a lot better in the platinum-sensitive group compared to the upfront, because these are truly platinum-sensitive. So I have a thing about these definitions. The definition of platinum sensitivity and resistance came about many years ago, and it's stuck, and people really haven't questioned it very much, but they're used widely. So when platinum sensitivity and resistance was first defined, it was based on progression, actually not even resist progression, it was based on clinical progression. So these are women who had had chemotherapy for ovarian cancer and then progressed, often clinically or radiologically. Remember, in the early 80s, CT scanning was at its infancy. And there's a world of difference between someone who's completed chemotherapy for ovarian cancer, who has a rising CA125 4 months after stopping chemotherapy versus someone who's got a 10 centimetre mass in her pelvis. And they both call platinum resistance. And so how you define sensitivity and how you define resistance makes a big difference. And now these terms are used for first line, second line, third line, and beyond. And there are real problems with these definitions, and I think they really have muddied the waters. And so when you look at trials of so-called platinum-sensitive ovarian cancer, it's really important to try and understand who are the population. Are these women entered in the study because they had a CA125 that went up 6 months after treatment, after completing treatment, or do they have resist progression 2 years or 3 years later? Those are different populations, and they're going to respond differently to second line or subsequent treatment, and I'd argue also to PARP inhibitors. And using platinum sensitivity in conjunction with your HRD score is, I think, critical, at least in the clinical setting, if not in clinical trials. Now, moving to some of the trials in a bit more detail. These are the platinum-sensitive population, and this is Ariel 3, rucaparib. And you can see in this particular study, I'm going to focus on the BRCA wild type with high LOH, and 28% were LOH high in the BRCA wild type, and they used the cutoff of 16%. And you can see that in the LOH high versus LOH low, there clearly is a big difference in favor of LOH high, but this really wasn't good enough at discriminating between a group who's not going to benefit, and even in the LOH low, we did see some clinical benefit. So it's good to discriminate in clinical trials, but whether in fact we can use this and how valuable it is in the clinical setting, I think is questionable. And I think you've got to once again take into account the clinical factors, the degree of sensitivity, the site of disease, and multiple other factors, because I just think using a cutoff of 16% really isn't enough. Now, in the NOVA trial, which is a maintenance trial, I'm going to focus now on the non-gene BRCA population. And if you look at these, the germline clearly do very, very well, and the non-germline BRCA with HRD positive also have a significant benefit. But it's important to also recognize in the NOVA trials in particular, they included somatic BRCA in the HRD positive, which obviously in some ways improves or increases the likelihood of progression-free survival. And if you look at no germline BRCA mutation, once again in favor of niraparib. But this is important to understand that the HRD population definitely do seem to benefit, and it is contaminated to some extent with the somatics. The quadra, I guess, gets to the point about even if you are HRD and you've had multiple lines of treatment, and these patients have had at least 4 or more lines of treatment for recurrent ovarian cancer, there was a lot of patients who were HRD positive, 189 in the study, and you can see that if they were platinum sensitive, the response rate was about 26%, and if you're platinum resistant, it was a lot lower. So even though they're HRD positive, platinum sensitivity makes a difference, but even in this particular setting, because they had so many lines of treatment, even though they're HRD positive, it doesn't necessarily mean that they're going to respond to treatment. So common sense should always prevail, and understanding how many lines of treatment, and particularly if patients have progressed while on treatment, because that usually is a pretty good clue that they're not going to respond very well to subsequent treatment. So platinum sensitivity always counts. The maintenance trials, which we've all heard about, the PRIMA, the PAOLA, and the VALIA, they all showed clear and unequivocal benefits in the BRCA population. No question about it. They all used Myriad MyChoice, but PRIMA and PAOLA used a cutoff of 42, and the VALIA used a cutoff of 33. And I'm not going to go through the design of the trials because you know them well, but I'm going to talk about the HRD. But if you look at them, they're pretty similar. About 30% or so of patients had BRCA mutations, and about 50% in total are HRD. Interestingly, and we haven't talked about this, in about 15% to 20% that's HRD unknown. It's for technical reasons. It just fails. It doesn't work. And we can't forget about that. There are many reasons why it doesn't work. Sometimes it's technical. Sometimes the blocks are old and they hasn't been fixed properly. So you're often going to get, or maybe up to 20% of the time, the results are going to fail. Now, these trials all showed there was a clear and unequivocal benefit in the BRCA population and in the HRD positive population. Remembering, of course, that HRD positive included BRCA. When you remove BRCA and just have HRD positive BRCA wild type, there's slightly less. The hazard ratio is less, drops to about 0.5. HRD negative in PRIMA was 0.68. I'm going to come to that in a few moments because I think there's a problem there. And interestingly enough, when you look at the HRD negative or unknown Impala, no benefit at all. And whereas in the others, there was a benefit. And in Velia, the main benefit in Velia, once again, it's the populations of patients are different. In Velia, it was really only the BRCA population who benefited from treatment. So this is HRD negative. In Velia, even though the hazard ratio looked like, just 0.8, there's really no meaningful difference between those two curves. And in Paula, no difference either. So I think we can select out a group of patients, at least in the maintenance setting, first line, who are HRD negative or are not going to benefit. Now just look at the PRIMA data. There's no patient numbers, there's no censoring, and the curves are exactly the same. They parallel each other. I just don't get it. How did that happen? Now, that wasn't in the New England Journal of Medicine, but that's what has been reported. So I still think, even though that showed a difference, I'm not convinced. So I personally think that if you have an HR proficient tumor based on Myriad in the first line setting, I personally wouldn't be trying to convince a patient to have a PARP inhibitor. I think there are better things you can probably do, such as bevacizumab or whatever else, but I just honestly don't think the data there support a PARP inhibitor. So there's some limitations of these maintenance studies. First of all, response to platinum is impossible to assess in many patients who have had optimal or even suboptimal residual disease. We just don't know. There are limitations of resistant ovarian cancer, and CR at the end of 6 cycles is a misnomer. We cannot be confident that it reflects platinum sensitivity in all patients. And platinum responsiveness is a continuum. One way that I think we might possibly be able to predict which patients truly have HRD in the first line setting is looking at the chemotherapy response score. So more and more patients are having upfront chemotherapy, neoadjuvant chemotherapy, in some cases up to 50%. I think that's far too much, but that's what's happening. But the chemotherapy response score, which is what the response in the omentum is, if you have a CRS score of 3, and that means that you've really got essentially a complete pathological response, that's up to about 30% of patients have that. Those patients do very well. If you have a CRS score of 1, and that's where the tumor looks very, very healthy, there's tons of cancer there, it essentially hasn't worked, those patients do really badly. And then you've got the CRS2, which is somewhere in between. So you could potentially use those and incorporate that into your clinical practice if you're doing neoadjuvant chemotherapy, and if you have a CRS3, then that patient probably has an HR deficiency, and you may not even need to go beyond that and just use that as a pragmatic approach. If they have a CRS1, I wouldn't be rushing in to give them a PARP inhibitor unless I knew that they actually had a HR deficiency, and even then it may not probably work. Now, unfortunately, no one's actually been able to relate response in the neoadjuvant setting to benefit from PARP inhibitors. But one thing, if you go back and look at the SOLO-1 data and look at neoadjuvant, and there are many reasons why people have neoadjuvant chemotherapy, sometimes because they're not well enough to have upfront surgery, but sometimes because of convenience or because it's just an easier thing to do. But if you look at the outcome in patients who got neoadjuvant chemotherapy, it is much worse than upfront surgery. Now, part of that might be selection, but part of it may possibly also be due to BRCA reversions. I don't know if it's such a good idea to be giving people who've got large, bulky tumours a lot of platinum up front, because there's high mutation rate. I think there's potentially the possibility of developing BRCA reversions, and in fact there are some data to support this. So that's just a mind bubble or thought bubble, but I just threw that out there. We've heard about prostate cancer, so I'm not going to spend any more time on that because we've just heard about that. So just in conclusion, beyond BRCA, HRD to predict PARP benefit. So I think firstly, there's a limitation of using genomic scars. It's a myriad assay, hardwired, static, even if there's restoration of HR function. The HRD assays, they have a way to go, but they do, at this point in time, they do identify a subset of patients likely to benefit, and the patients, particularly in the frontline setting that are HR proficient, I think do not benefit from treatment. I think it's a little bit less clear in the recurrent setting because platinum sensitivity may trump all these things. Functional biomarkers are probably going to be where we're going to be going, but at the moment there's lots of technical issues with them. And I think we can use extreme platinum sensitivity, multiple responses to platinum as an indicator of HRD-ness in the recurrent population, in particular select patients. And in the first-line setting, it's the BRCA mutants and the HRD subset that benefit the most. And thank you very much.
Okay, so I'm going to move on. So the third talk in tonight's symposium is actually a little bit different from the first two talks. And basically, what I'm going to do is to share with you some real-world cases of patients who have actually undergone BRCA and beyond testing, both in the germline setting as well as in the tumor setting. I'm going to use some examples to basically illustrate some key principles in testing in this area. So just a brief background of the cancer genetics program that we run at our hospital here in Singapore. This is the National University Cancer Institute, Singapore. And we have been running a cancer genetics program since 2001, so it's been quite a long history. What we do in these clinics is that we evaluate the patient's genetic risk based on the personal and family cancer history. We provide genetic counseling, also offer genetic testing in appropriate risk patients, test interpretation, and also formulate screening and preventive recommendations. Just to highlight, this is an adult cancer genetics clinic, so we are not limited to seeing patients with hereditary breast cancer syndrome, but it is the most common group of patients. The second most common group of patients are those with suspected hereditary colorectal cancer, and then the remaining 20% is a mixture of rarer conditions like multiple endocrine neoplasia, von Hippel-Lindau syndrome, hereditary paraganglioma, and so on. So traditionally, the people who come and see us in the clinic are patients who fulfill clinical criteria that you suspect that they may have hereditary cancer syndrome. And in cancer genetics testing is actually quite strict in terms of the principles that we follow. So the patient must be of sufficient risk, and most guidelines would recommend that the patient must have an a priori risk of at least 10% of carrying that genetic mutation before genetic testing should be considered. So these are some descriptive criteria of when to refer a patient for hereditary breast cancer testing. And based on these criteria, probably less than 10 to 15% of all the cancer patients that you would see in your clinic would actually fulfill criteria for testing. But as we have heard from the first two speakers, and as you probably know, in the last 3 to 4 years, there have been what we call therapeutic indications for doing genetic testing, particularly BRCA testing, because of the availability of PARP inhibitors. So on this slide, I summarized the key FDA-approved indication as well as key phase 3 randomized trials that's related to BRCA mutation and PARP inhibitor use. So we have two cancers for which there's an FDA-approved indication. So BRCA mutant ovarian cancer as well as BRCA BRCA mutant, HER2-negative breast cancer to warrant the use of PARP inhibitor. And then, of course, more recently, we have a phase 3 randomized trial for pancreatic cancer, which is BRCA mutant. So here I want to highlight the first 3 indications, and you can see the commonality here is that BRCA germline mutation will actually warrant these 3 patients with these 3 tumor types to be treated with a PARP inhibitor. But there is an exception here, which is ovarian cancer, and that was covered quite extensively earlier on, where somatic mutations, so if the patient has a tumor mutation, ovarian cancer, it also qualifies the patient to be treated with a PARP inhibitor. But I just want to highlight that the same is not true, at least currently, for breast cancer and pancreatic cancer. Then this trial has also been mentioned. This is the PROfound trial, which is just presented at ESMO this year. And essentially, this is a little bit different because it's firstly it's metastatic castrate-resistant prostate cancer, but here the biomarker is in the tumor, and it's a panel of mutations in homologous recombination genes. But there are BRCA listed here, it's very small listed here, but BRCA1, BRCA2, and ATM is in cohort 1, and there are a number of other genes that are involved in homologous recombination. So today, if we want to do a test to identify patients who could benefit from a PARP inhibitor treatment, there are a number of tests. So first, you could do germline testing for BRCA mutations, and that would be relevant for ovarian, breast, and pancreatic cancer. And then you could also test for the tumor for BRCA mutations or a more extended panel of homologous recombination genes that could be relevant to prostate and ovarian cancer. And then there is also the genomic instability score test, which would be relevant to ovarian cancer. So for the tumor BRCA testing or the tumor HRD mutation testing, usually you get that information from a tumor NGS test. Whereas for germline BRCA mutations, we'll get this, could be a single gene test, it could be a multi-gene panel test. So today what I'm going to do is mainly focus on the germline testing for BRCA and beyond, as well as tumor NGS tests, and I'll illustrate with some examples. So firstly, testing for germline mutations in BRCA and beyond. So I've mentioned earlier on that really today, if I see a patient in our cancer genetics clinic, they really fall into 2 categories. So the first group are patients, the traditional group, so those patients who fulfill conventional criteria for genetic testing. So here you see the main motivation would be screening and prevention for both the patient and the family members. Then there is a second distinct group. So these are patients who fulfill therapeutic indications for testing. So these patients invariably will have advanced metastatic cancer. That's why they fulfill criteria for therapeutic indication. So you can see there's a very clear focus, which is on the patient. They want therapeutic reasons. And the prevention, screening, and all that is actually of secondary interest to the patient. So here I do want to just highlight this point that because in the clinic, if you have a metastatic patient, you're testing for therapeutic reason, you're all engrossed about getting that information for therapeutic, you may forget that the information that is yielded is heritable. But so this is just sensitive information. So it's a reminder that regardless of the indication for testing, genetic counseling remains important. Another important point, which is what we really need to accept, is that because of the widening indication for therapeutic reasons, increasingly more patients become eligible for testing. So, and no country will have sufficient cancer genetics resources to see all these patients. So invariably, many of these patients will have to be tested outside the context of a cancer genetics clinic. So it's actually quite important for oncologists, surgeons who may encounter these patients to be aware of the do's and don'ts of genetic testing. So one important thing when you want to do these tests is choosing the right test. And when we say choose the right test, there are several things to consider. You need to choose the right lab, you need to choose the right methodology, and you need to choose the right genes. So why do we need to choose the right lab? The reason is because most hospitals will not have their own in-house BRCA testing. So generally, if you need to do BRCA testing, most people are using a third-party lab or third-party vendor. But this part is actually not so difficult because all you need to do is to ensure that you choose, if you are the one choosing the lab, just choose a lab that has accreditation that is either clear or CAPS certification or equivalent. Probably more important is to be sure that you choose a lab where the methodology for the BRCA testing is appropriate. So BRCA mutations are distributed across the entire genes and there are no hotspots. Majority of the mutations are single base pair substitutions or small indels, so small deletions, insertions. So therefore, the very basic methodology that must be included must be a full sequencing of the 2 genes. But in addition, about 10 to 15% of BRCA mutations are large deletions, rearrangements, duplications. So therefore, you must make sure that there is a second methodology, which is a deletion duplication analysis or an MLPA analysis. So now I want to illustrate one case. So this is a patient with young onset breast cancer at 33, no family history, so you suspect that the patient may have hereditary breast cancer. Offer genetic counseling, you provided genetic counseling and recommended genetic testing. And the patient says, I've already done this test called 23andMe, and it says that there was nothing wrong with my breast cancer genes. So maybe just a brief show of hands, how many people know what's 23andMe? Some, okay. So let me just review what is 23andMe. This is an online test. It's direct to consumer. If you look at the methodology of the test, this is a custom-designed SNP array. So it's actually quite an extensive test. It's across the genome, many, many genes, covering more than 600,000 SNPs across the genome, including the BRCA gene. So now I'd like to poll the audience. Given this result, given this understanding, does this patient still need BRCA testing? Yes? Show of hands. Yes? No? Not sure? So the answer is yes, the patient still needs BRCA testing because 23andMe does not comprehensively sequence any gene. So this is not the correct test to detect BRCA pathogenic mutations. So just a reminder that proper BRCA testing must include full sequencing and deletion duplication analysis of the entire gene. Then the next question that you need to answer is, how many genes should I test? Should I just test the BRCA1 and 2 genes, or should I do a multi-gene panel test? And the reason why there is this option is because in recent years, next-generation sequencing is becoming more widely available. So this is a technology that allows several genes to be bundled together. So usually tens to hundreds of genes bundled together. And the advantage of NGS, why we like to use it, is because it is less labor-intensive, so it is cheaper, shorter turnaround time, and importantly, because you are testing multiple genes, it can cover differential diagnosis. And covering differential diagnosis is a good thing because if you're trying to diagnose hereditary breast cancer syndrome, you'll know that while the BRCA genes are probably the most well-known genes, they are not the only genes that can cause hereditary breast cancer syndrome. So this table summarizes some of the key high to moderate penetrance genes that can increase the risk of breast cancer. Some of them also increase the risk of ovarian cancer, and then others may increase the risk of other kinds of cancers. And also, therefore, you can see diagnosing these other conditions will have its own screening and preventive implications. And I've also highlighted in blue genes that also belong to the homologous recombination pathway that were highlighted earlier on. These are germline. So it is possible that in the future, diagnosing these conditions may actually have therapeutic implications, just like what we are seeing now with BRCA mutations. So because of the wider availability of NGS, actually this is already being used in the clinic. So NGS testing is increasingly being used in the clinic to diagnose hereditary conditions. So in our own clinic, we have been fairly routinely using an NGS or multi-gene panel test since 2015. So this is a data set of 460 patients. These are all at-risk individuals, at least 10% chance of carrying a genetic mutation. And we tested them, initially was a single gene test, but after 2015, actually majority of the patients were tested after 2015, and it was with a multi-gene panel. Overall, 30% of patients were found with pathogenic mutations, 43% had no mutations, and 27% had a variant of uncertain significance. So if you were to look at the distribution of the pathogenic mutations, you can see here that about 80% of the pathogenic mutations are in BRCA1 and 2, so they remain key players. But because we did a multi-gene panel test, you can see other mutations, other genes being identified. So there's TP53, PALB2, BRIP1, ATM, CHEK2, and so on. So overall, 20% of identifiable pathogenic mutations are in genes that are beyond BRCA1 and 2. So just give you some specific examples. So this is a patient with ovarian cancer at age 49. Not much family history to speak of. She's referred specifically for PARP inhibitor. And basically, we estimated 10 to 15% chance we might find a BRCA mutation. Did a multi-gene panel test. Patient did not carry a BRCA mutation, but instead was found with a RET51C mutation, which is a low penetrance gene for breast and ovarian cancer. There may be therapeutic implications, even though this is not a BRCA mutation, because there is emerging evidence to show that these patients may be more sensitive to platinums and PARP inhibitors, just like BRCA mutation carriers. This is another patient with young onset breast cancer at 34. There is paternal as well as maternal family history of breast cancer. We estimated about 15-20% chance we might find a BRCA mutation. We did a multi-gene panel test, and again, there's no BRCA mutation, but this patient carries a pathogenic mutation in the CHEK2 gene, which is a moderate penetrance gene. This gene increases risk of breast cancer only, but not ovarian cancer. So screening implications is on breast cancer only, and there's currently no therapeutic implications for this particular gene. Then this is another patient with double primary cancer, initially breast cancer at 41, and then subsequently colon cancer at 53. Sister has ovarian cancer, so this is a breast ovarian cancer family. So we estimated 30 to 40% chance we might find a BRCA mutation, did a multi-gene panel test. Again, no pathogenic BRCA mutation, but the patient actually has a pathogenic mutation in MSH6, which is a mismatch repair gene that causes Lynch syndrome. So the screening implications for this patient is completely different from BRCA. We're focusing on colorectal and endometrial cancer. And also it has therapeutic implications, not for PARP inhibitors, but for immune checkpoint inhibitors. So the advance of multi-gene panel testing does allow us to diagnose more people in the clinic, a wider range of genes, some of which have therapeutic implications. And if you were to look at the testing landscape, there are actually a spot for choice to choose the vendors. There are many vendors out there. It's highly competitive space, so the test cost has also reduced quite significantly, and the test is becoming more accessible. But one challenge when you're doing multi-gene panel tests is that how many genes should you test, and what are those genes? And even if you use NGS testing, you could just choose to test perhaps BRCA1 and 2, or this vendor that we use fairly commonly actually has what they call a 11-gene guidelines-based panel, which are more stringent genes. They also have a wider breast cancer panel, which is a 26-gene panel, so they include some lower-level evidence genes. And then there is a wider 46 common hereditary cancer panel, which would include hereditary cancer genes. And because this is NGS and they've already bundled the genes together, the good thing or the bad thing is that regardless of how big is the panel, the size, the cost is the same to the patient. So it makes it very tempting for you to order a very large panel of genes. The problem here I do want to warn people is that while it's very tempting to order a very large panel, when you're doing hereditary cancer or germline testing, you really need to be cautious about indiscriminately ordering a very large panel. Of course, for tumor NGS testing, this is completely different. So if the vendor wants to put in more genes, it's fine. Maybe the additional information is not actionable, but it's not, at least will not be harmful. But germline is a little bit different because if you test more genes, you might get unwanted information, you could get variants of uncertain significance. So these are things to consider. So for germline testing, you have to be more prudent and not indiscriminately order a very large panel. So firstly, variants of uncertain significance, which is uninformative and not actionable, they would definitely increase if you test many genes. So this is our data set of 254 breast cancer patients tested in our cancer genetics clinic, all underwent germline testing. And basically, we went back and simulated, used the data and simulated how will the diagnostic yield and the VUS be impacted if we reduce the number of genes that we tested. So we actually test up to 49 genes, but what happens if I test just 2 genes, 6 genes, 15 genes, or 21 genes? And you can see that the red line is the diagnostic yield, the blue line is the VUS rate. So clearly, as you increase the number of genes that you test, the diagnostic yield will increase, but so will the VUS. But here you see, look at the diagnostic yield. Beyond about 20 genes, it sort of plateau off. It doesn't increase much more. So any additional genes beyond 20 would probably be genes that are not relevant to the patient's condition. But yet the VUS rate is going up. And up to a certain point at about 30 to 40 genes is when the VUS rate exceeds the diagnostic yield. So that's the point that you really want to avoid crossing. So what's the optimal number of genes? We think probably in the range of about 15 to 20 genes, where you are actually maximizing the diagnostic yield, and yet the VUS rate is acceptable at probably less than 20%. Next, I'm going to illustrate one case, use this case to illustrate why it is important not to test an indiscriminately large number of genes. So this is a real example, a patient with breast cancer at 32, so young onset. There's paternal family history of ovarian cancer, maternal family history of colon and breast cancer. So the primary oncologist very appropriately suspected BRCA, but went ahead to order the test and selected a very large panel. This is an 83-gene panel. So this testing showed that the patient has a BRCA1 pathogenic mutation and no other variants, no other VUSs, so that's a good outcome. Then this patient has the 30-year-old sister who came, and we know that she has 50% chance of carrying the same mutation. So now I want to poll the audience again. So which test should you order for the cancer-free sister? So there are a few options here. Okay, so how many people will test the full 83-gene panel? Some people will go for the 11 gene guidelines-based panel. Okay, full BRCA1, single site mutation analysis. Okay, so the correct answer is single site mutation analysis because a mutation has already been identified in this patient. So, but this oncologist, basically the patient was seen by the oncologist who went ahead to counsel the patient's cancer-free sister and ordered the same 83 gene panel. So let's take a look at the outcome of this testing. So this is the patient's cancer-free sister's result. So very fortunately for the sister, there is no BRCA1 pathogenic mutation, but because an 83 gene panel test was ordered, there were several other findings here that was not found in the original patient. So first, there is a likely pathogenic mutation in a gene called MARYH. There is a VUS in BRCA2. There is a VUS in PEL-B2, which is also a breast cancer, high penetrance breast cancer gene. So as I mentioned earlier on, VUS is uninformative, but if the patient has that result, it causes uncertainty. So it really can cause anxiety in the patient. And also a likely pathogenic MARYH mutation can marginally increase the risk of colorectal cancer, but it's somewhat controversial what you should do about that. Not sure whether they would benefit from earlier screening, but yet the information is sufficient to impact on the patient's insurability. So the moral of the story is that you don't test unnecessarily large number of genes. So all this information could have been avoided if the correct test was done. So how do you choose the correct test is really context dependent. So if the patient fulfills conventional criteria for genetic testing, i.e. there's an estimated at least 10% chance that we might find a genetic mutation, then they may benefit from a multi-gene panel test, but it may be better to test such a person in a cancer genetics clinic. On the other hand, if the patient only fulfills therapeutic indication, but does not fulfill the conventional criteria, then it may be better to just test BRCA1 and 2. Just bear in mind, it should be full sequencing and deletion duplication analysis. And if you have the chance to have to manage a cancer-free family member of someone where there is already a pathogenic mutation found, then the correct test to order is single-site mutation analysis. Then after you have ordered the test, now the next step is to interpret the test right. So I'm going to use some examples to illustrate how to manage VUS, incidental unexpected findings, and how to interpret tumor NGS results. So this is a patient with breast cancer at 31. You can see very strong family history, so there is both male and female breast cancer in the family as well as ovarian cancer. So we estimated more than 50% chance we might find a BRCA mutation. Did a multi-gene panel test, and the patient was found with a BRCA2 missense mutation that is classified as a variant of uncertain significance. There are no other deleterious mutations found. So like to poll the audience again, how many people think that the BRCA2 VUS is likely to be pathogenic given the strong personal and family cancer history? Yes? No? Not sure? Okay. How many people feel that this result supports the patient to be treated with a PARP inhibitor? Yes? No? Not sure? Okay. How many people feel that this patient's cancer-free sibling should undergo predictive testing for the BRCA2 VUS to determine the cancer risk? Yes? No? Not sure? The answer is no to all 3 questions because the VUS is uninformative and not actionable. This is different from Shahina's case because she has 3 sisters who all have cancers and who have the same mutation, but even then she cannot be 100% sure it's likely pathogenic. But the way she managed that patient is appropriate, but if you just see a VUS does not mean it's likely pathogenic. So this is another patient, a patient with breast cancer at 49, and there is family history of breast and ovarian cancer. So you can see quite strong suspicion of a BRCA mutation. We estimated 30 to 40% chance we might find a BRCA mutation. Did a multi-gene panel testing, and we were right. The patient does carry a BRCA2 pathogenic mutation. But what was surprising is that there was another pathogenic mutation in this test result, which is a RET mutation. So maybe I'd like to poll the audience again. Do you think that the RET mutation increased the risk of breast cancer? Yes? No? Not sure? Okay. So what does the RET mutation do? Essentially, this is the gene that causes familial medullary thyroid carcinoma or multiple endocrine neoplasia type 2. If someone has this mutation, you expect to see medullary thyroid carcinoma, pheochromocytoma. This is a very serious finding because there are actually very clear screening and preventive recommendations for such patients. But one important thing, if you do the test and you find this, is to recognize that actually the RAP mutation, the finding is discordant with the clinical history. So we actually were worried about a lab error. So what we did was that we made the patient take a second blood sample and send it to a completely different lab, just to be sure. And the mutation was actually confirmed. So this is a very rare, unfortunate individual who actually inherited two mutations in two different genes. Both are fairly rare conditions. She had two daughters who went on to be tested, and quite unfortunately, she had passed both the BRCA2 as well as the RAP mutation to one of her two daughters. The other daughter is fine. So this is an example. If you actually were to do a multi-gene panel test and you find something serious like this, it's actually quite important that you should refer this patient to be managed in a cancer genetics clinic. Next, I'm going to move on to interpreting tumor NGS results. And really in the clinic, if you're practicing oncologist, you will increasingly see these results because we are increasingly ordering tumor NGS testing for patients with refractory cancer. So the question is, how do you interpret that BRCA test result that actually comes out in that tumor NGS report? So this is a patient with refractory breast cancer, underwent tumor NGS testing, and there is, among various genomic alterations, is a BRCA1 nonsense mutation. So this is a pathogenic mutation. So now I want to poll the audience again. Is the BRCA1 mutation germline or somatic? So how many people think it's germline? Somatic? Not sure. Okay. Is the BRCA1 mutation heritable? Yes? No? Not sure? Okay. And can the patient be treated with a PARP inhibitor? Yes? No? Not sure, okay. So in order to answer these questions, we need to basically understand the fundamental difference between germline and somatic. And actually, there is still some confusion between germline and somatic among some physicians. So I think it's worth spending just one slide to discuss this. So germline information refers to heritable information. It does not change with time, so you just need to test once. Somatic information is non-heritable. It could change with time, so you may require serial sampling. So the usual indications for germline testing is, like, for example, diagnostic to diagnose hereditary cancer syndrome, whereas somatic testing is therapeutic, for example, EGFR mutation testing. Because germline testing yields heritable information, pre-test genetic counseling is crucial, but you don't need that for somatic testing. What about starting materials? For germline testing, it's most commonly blood. For somatic testing, it's most commonly tumor. So most of the time, we will associate blood testing with germline information, tumor testing with somatic information, but this relationship is not exclusive. So for example, tumor originates from normal tissue, so it actually does contain germline DNA. So when you do a tumor test, you could potentially yield what we call incidental germline finding. But the important question is how likely. So if you were to do a tumor NGS test, what is the probability that you might find incidental germline pathogenic mutations? This is a study from MD Anderson, 1,000 patients that underwent tumor NGS testing. It's a large panel of 202 genes. All the patients provided PET, blood or saliva sample as a germline control, so it is possible to ascertain each tumor mutation, is this germline or somatic. This is a focused analysis on 19 cancer predisposition genes, including BRCA. And overall, about 5% of tumor variants that were identified are germline in nature, so this would represent incidental germline findings. But the prevalence, it actually varies between different genes. So for example, tumor TP53 variants are pretty common, but only a very small minority, about 3%, were germline. On the other hand, tumor BRCA variants are not very commonly found, only 3% of the time, but the vast majority, 80%, were germline. So if you come back to this patient, is the BRCA1 mutation germline and heritable? It's actually a high probability that it is germline and heritable, but you actually cannot be sure. So the correct answer is not sure. And this is potentially an incidental heritable finding. Can the patient be treated with a PARP inhibitor? In the context of breast cancer is no, because if you look at the US FDA label, the approval language is specifically only for BRCA germline mutation, but you could confirm this on a blood test, and if the patient is confirmed to have a germline mutation on blood taking, then you could actually then treat the patient with a PARP inhibitor. So this is how we interpret if we find a mutation, a BRCA mutation on tumor NGS testing. But what about the opposite scenario? So this is the opposite scenario. A patient with young metachronous breast cancers, age 25 and 30, so again, strong suspicion of carrying a germline mutation. You provided genetic counseling, wanted to do genetic testing, and the patient says, I've already done this test called Tumor Foundation 1. Many, many genes there, including BRCA, and there's no mutation in the BRCA genes. So now the question is, does this patient still need BRCA germline testing? So again, poll the audience, yes. Does this patient still need germline testing? No? Not sure? Okay. So the question here is how reliable is tumor BRCA testing to completely exclude germline mutations? We did this study actually with Genomics. We just published it this year. 60 patients who have undergone germline testing in our clinic. So we knew exactly what their germline status is. And we retrieved the paraffin-embedded tumor samples and sent it to the lab for tumor NGS testing for BRCA1 and 2. The lab was blinded to the germline results. We did not give them a blood sample or germline sample as a reference. We just asked them, test the tumor, use your algorithm, and tell us whether this patient harbors a germline pathogenic mutation in BRCA1 and 2. So how did the tumor test perform? So there are 60 patients, 38 had no germline mutations, and the tumor test was perfect, 100% concordant, no false positives at all. But among the 22 patients with pathogenic BRCA mutation, the tumor test could only detect 70% of those mutations. So there is a 30% false negative. And what were the reasons? Half the time it was a technical error, which means that the mutation just simply couldn't be detected in the tumor. And the other half of the time is what we call an interpretation error, which means that the mutation is actually there, but the algorithm that was used in the lab wrongly classified it as non-pathogenic or non-germline. So the bottom line is that tumor BRCA testing is pretty good in identifying the mutations, but it's not exhaustive. So if you don't find a mutation on tumor NGS, but the patient fulfills the regular conventional criteria for testing, then you would still need to do the germline testing. So the key take-home messages for tumor NGS is that before you actually send off that tumor NGS test, you should be mindful that there is a small chance that you might yield incidental germline findings. So it will be good to do a brief pre-test counseling to warn the patient. And if the tumor NGS test yields a BRCA pathogenic mutation, then there is a high probability that this is going to be germline. So the correct course of action is to offer the patient proper genetic counseling as well as confirmatory tests using a direct germline test, which is a blood test. On the other hand, if the tumor NGS test yields no BRCA mutation, then we should note that not all germline BRCA mutations can be detected in the tumor. So if the patient fulfills criteria for testing, then germline testing should still be done. So to conclude, there is now widening indication for BRCA and beyond testing for therapeutic reasons. But if you look at the data, you will notice that some PARP inhibitor data approval is based on germline mutations, others is based on tumor mutations. So this is still an evolving area, but you must be aware of the differences. Just be aware that germline and somatic and tumor is not necessarily the same, and they are not interchangeable. Because of the recent availability of NGS testing, which is now applied both in blood as well as tumor testing, this has facilitated the diagnosis of a broader spectrum of gene mutations that may have therapeutic implications. But while you're doing these tests, you may actually be doing germline testing. So a reminder that germline testing yields heritable information, so we really need to exercise more caution. Thank you.
Thank you very much for Prof. Lee and all the other speakers as well. I think we've had a really excellent session talking about BRCA to HRD and really covering both clinical trial research as well as clinical use and going deep into the testing as well. We are now going to have a small panel discussion, so we invite both of the speakers still here, and the panel discussion will be moderated by my colleague Song, who is also the regional medical manager.
Yeah, so good evening, everyone. Thanks for still staying with us. So we are going to shortly start the panel discussion. So before starting, please allow me to actually summarize a little bit on the testing itself. So I guess just now it has been very comprehensively talking about what actually is BRCA testing, what actually is HRD testing, and most likely that we now actually know that we can actually go from two angles. One angle is actually you are measuring the cause. What actually causes HRD? It can be actually the BRCA mutations. Here we are actually most likely talking about the pathogenic germline mutations, but actually also the somatic mutations, but pathogenic sense. And the other probability is actually looking at homologous recombinant repair pathway genes mutation. And this is actually measuring the cause to know whether the patients might have HRD. But of course, there is another angle that we can look at HRD, which is we are directly measuring the effects, and that will be actually measuring the HRD score. So it can be genome-wide scoring, just like Myriad, or it can be actually panel testing to infer genome-wide instability, which will be the LH score. So there is still now a lot of debates, as just now, Professor Michael has demonstrated and also elucidated that either if you are actually carting at like 42 or actually in 33, you're actually seeing different kind of like effects from the patient that is treated with PARP inhibitor. So now maybe we actually open the floor, and I welcome everyone that either you want to submit like the card to the questions, or just I can just pass down the microphone for you if you have any questions. If not, maybe let me start first. So in terms of the HRD testing for both Prof. Michael as well as Dr. Lee, right now, do you think you will actually start it with like the score, or you will actually start it with what gene is mutated, or you are thinking that both are actually equally important when you want to test for your patient in treatment or in maintenance?
Well, I don't think there's a simple answer, but I think that germline BRCA and somatic BRCA trumps everything. And if you don't have a germline or somatic BRCA, then I think that HRD, and whether you're using Myriad, which is typically what people are now using, I think that's a reasonable test. And you'll pick up a lot more using the HRD assay than you would looking for specific mutations in a few homologous recombination repair gene path. So we would normally just go for germline or somatic BRCA. That's what we tend to do usually, and then add in. Now the problem, I guess, is also dependent on the circumstances and availability of drugs. We are able to, in Australia at least, access PARP inhibitors for certain indications, and that is if you have a germline or somatic BRCA. We do not have approvals as yet for HRD. That's probably going to come, and then it probably will be tied to a diagnostic assay, probably the Myriad. So a lot of it is contingent on the jurisdiction you work in. Whereas I guess in people who are in private practice or where people are self-funding, it's going to be a little bit different. And then obviously it's a conversation you have to have with the patient. And I think it's also important not to overcall the results. I think in the first line setting, I think the results are very impressive, but patients often don't understand the difference between progression-free survival and overall survival. So you have to be a bit careful about that, because at the moment, we actually do not have any data that PARP inhibitors improve overall survival.
I have a question regarding what you said about maybe testing for BRCA germline, and then if you don't find it, you might test the BRCA somatic mutations. So in your experience, what is the likelihood of still finding a BRCA somatic mutation if the germline mutation is absent? Because we did a small study, and we had patients that had germline, that we did the germline mutations testing first, and then when there are no mutations and we went on to test the tumors, the likelihood is very, very small.
So it is small, but it also depends on when you test. So if you look at initial diagnosis, it's 5%. You'll find it somatic. So 1 in 20. So that's what we normally counsel patients. But if you are testing patients who are platinum sensitive and had 2 or 3 or 4 lines of treatment, you've selected out a subgroup who are probably more likely to have a somatic BRCA, and it may be probably closer to maybe 10%.
So maybe I follow up with the question then from Prof. Lee. In this case, would you start with germline testing, or you will start with somatic testing?
So we, was it for me? Okay. So we routinely do germline testing first. And we're now struggling, and I'll be very interested to hear what you think, we're now struggling with whether we should in fact be just looking at tumour first and then go to germline, but providing there's MPLA included, so we don't miss the large-scale deletions, because we can get it done very rapidly at no cost.
So I would say in our practice, we really rarely send the tumor for BRCA mutation testing. if you do get it, it is part of a larger panel to look for multiple other things, not specifically for BRCA. And the reason is because, firstly, germline, as you know, there are some technical challenges with testing the tumor. Really depends on how old the sample is. You may not pick up all the mutations. So germline mutation is much cleaner. So for sure, you'll be able to identify the germline mutations. But as you said, that there are other challenges in that you cannot just send the test without doing genetic counseling. So there is a step, there's a process, and that could actually be an obstacle for some patients if they don't have easy access to genetic counseling services. So you do need genetic counseling, and the advantage of somatic testing is that it doesn't come with all the sensitive information. And if somatic information is already sufficient to guide the therapeutic choice, then you can actually save the germline test.
Is there any other question from the floor?
Yeah, maybe I will just ask one. And my question is more to Prof. Lee. You were mentioning those patients for whom you can find BRCA mutation in the tissue NGS panel. And then the conclusion, of course, is, especially if they're breast cancer patients, high risk of hereditary, you would want to confirm they are germline. Would you then actually just do a Sanger sequencing for that specific mutation that was identified, or would you order a full BRCA panel for that patient?
I think that's a good question, but nowadays, okay, so probably you can do a single site, but we would probably order a full panel because the cost difference is very little now. So we use a vendor where the NGS testing for hereditary cancer is just like $500 to the patient, so it's very affordable. Yeah, yeah. Yeah, so Sanger sequencing, and in fact, the problem with Sanger sequencing is that now you got to tell the lab, I'm going to do a single site mutation analysis, and some labs refuse to do it for you unless you have tested the reference patient. So you may not be able to find it. So there are only so few labs that is willing to test a known mutation. So you tell them on to test for this particular mutation. Many labs will say no, they will not test it unless they were the ones who found it in the index patient.
Sure. Yeah. So really, if the lab, requirements are not an issue, and if cost for the panel would be higher, which I think in a lot of like private clinics it would be also in Singapore, then actually, do you think Sanger would suffice?
Yes, Sanger is you're right. So Sanger is perfectly sufficient. Yeah. The only thing, yeah. So yes, yeah. If a pathogenic mutation, if that means if the tumor test is quite sure there's a germline mutation, because sometimes the tumor test is wrong. But we really didn't have any false positive in this study. So at most, it's a false negative, at least in this study of 60 patients. Yeah.
Any questions from the floor?
In male breast cancer, you prefer test every case for BRCA mutation in male breast cancer.
Test?
Yeah, should be tested.
Yes.
Every case.
Yes. So my practice is that if there is a male breast cancer, I will test. It does fulfill the criteria. I guess it's the same in Australia. So any age, we will test. You don't always find it. Okay, so maybe average of a bunch of male breast cancer maybe have about 10-20% chance of finding a mutation.
Any questions? So maybe I'll also have a question for both Prof. So just now, actually, Dr. Shahina did mention that, for example, in prostate cancers, the somatic as well as the germline proportion is actually almost close to like 50-50, which is quite different from like in ovarian cancer or in breast cancer. So in this case, would you actually still go for like germline testing, or it will be more for like tumor testing, especially in Profound? Actually, what they see is not only just the BRCA, and they are actually starting in using the tumor testing when they want to actually look at the effects of the inhibitors. So what's your thought?
Sorry, I didn't get the question. Sorry, can you say it again? I missed the question.
Sorry, so like for germline and somatic testing for the BRCA in prostate cancer, which one you will choose first? Because the proportion is more like 50% to 50%, the mutation rates.
You're asking the wrong person. The last time I treated a male was about 30 years ago. So I know nothing about prostate cancer.
I think the current data, from what I Okay, I also don't treat prostate cancers, but from what I see from the data, currently there is, although it may not make sense, but currently there is no strong data or any phase 3 randomized data to support germline testing for prostate cancer, actually. So the strongest data is from the PROfound, which is the phase 3 randomized trial, and they did not use germline testing. They used tumor testing as a way to select the patients. They had 15 genes all along the homologous recombination pathway. BRCA is inside there. I think, granted, some of those patients who were enrolled probably have a germline mutation, but strictly, if this goes through to regulatory, it's going to be a tumor test and not a germline test. Yeah, so, but I mean, you're right. So biologically, many of these patients will turn out to have a germline mutation, but strictly, it will be, right now, if you base on the data, there is no reason to test germline for prostate, actually. Yeah.
Any question from the floor?
Everyone's tired. In the conference all day.
Maybe I'll ask the audience, how many people have done BRCA testing in their practice? And you send to a external lab? Okay, you test the panel or you test BRCA? Only BRCA, okay. For what is the reason? For therapeutic reasons? For therapeutic. You do genetics counseling? No. So, yeah. So actually pre-test genetic counseling is quite important, but I'm not sure what your experience is, but basically, because of therapeutic reasons, more and more people need that genetic counseling, so we are exploring, so how do you deal with that? Because there's more people, because do you still run a genetics clinic?
No, so we mainstream now, and so what that means is all the medical oncologists, and in fact quite a few of the nurse practitioners, now we counsel the patients in the clinic, and then anyone who's positive or has a VUS then gets referred to genetics.
So you have a workflow, so
Yeah.
so most people can do that pre-test counseling to get that test kick-started.
So we start straight away. We try and test everyone at diagnosis.
Yeah.
So if there isn't any other questions, so we are going to a oh, yeah.
How does cell-free DNA come into the picture?
The question is, how does cell-free DNA comes into the pictures?
I don't think it does come to the picture at the moment. I mean, it's a good question, and I think that it's often quite difficult. I mean, a lot of the times when we're looking at somatic mutations, it's based on tissue that was taken, 5 years earlier, and it's not always easy to biopsy. And I suspect that it will be useful as we move forward. And in fact, it may be very useful to pick up BRCA reversions. And there's a lot of work going now to try and pick up BRCA reversions. One of the scary things about BRCA reversions, and there's some data from David Botel's lab, is if you do biopsies from 10 different metastases, you can sometimes find multiple different reversions. So I think that's where I think it might be helpful in the future in picking the patients who have got reversions and who have no chance at all of responding to a PARP inhibitor.
I would like to also give some comments on the cell-free DNA, because I believe right now there is actually using like ctDNA to look at whether the patient is actually having like maybe somatic mutations like BRCA1, 2, especially in Galahad trial. They're actually using both the cell-free DNA as well as tumor testing. But I think it will actually also be affected when we are talking about what actually is the amount of cell-free DNA that actually can be released into the bloodstream. So in prostate cancer, maybe there will be a role for the cell-free DNA, but right now in the ovarian cancer or in breast cancer, maybe it will still need a little bit more of the trial data to give like an idea whether the sensitivity of detecting the circulating tumor DNA for somatic mutations is good enough or not. What's your opinion?
Oh, my opinion? No, I'm just a urologist. So with the NCCN guideline coming up for metastatic castrate-resistant prostate cancer, so these are indicated for somatic testing which you rightly point out. So I'm just finding out the different ways of answering the men.
Thank you. Is there any other questions? Okay.
Just maybe a last question to follow up on Prof. Michael's comment. You mentioned about those BRCA resistance reversal mutations. I'm just curious, in a clinical setting, actually, when and if and when would you actually do a secondary testing to find these mutations?
Look, we don't do them routinely. It's just part of a research program where patients with resistant disease, we're collecting tissue in all patients who progress, and we're looking at it as part of the Australian ovarian cancer study. But it is a very important mechanism of resistance, and it's something we're going to have to learn how to grapple with, and we're looking at whether there's collateral sensitivity to other drugs once you develop a reversion, what does it actually mean, how stable they are. It seems to be more common perhaps in BRCA1 than BRCA2, so I think we have a lot to learn about PARP resistance, but the more we use PARP inhibitors, we're going to have to face that.
Okay, so I think we are going to close the panel discussion. And before I welcome Professor Lee for the last closing remarks, we would like to actually also introduce a little bit about our testing. So we do provide both actually like germline BRCA testing as well as the somatic testing. And one of the features is that we actually do use the MLPA in order to detect whether the patient's BRCA1 and 2 is having any kind of like LGR. The other part is actually we do also provide the BRCA HRD, but here we are not providing the score. The methodology that we are using right now is basically looking at the HR genes mutation. So this is pretty much everything I would like to introduce. But if you have any other question, please feel free to look for my colleagues. They are all sitting behind. So we are always ready to actually talk. Like Wei Xiang is right over there. Then we actually also have like Jack over there, Imelda over there. I also see Bert and Sue over there. So thank you very much, everyone. And now let's welcome Professor Lee for the closing remarks.
All right, so thank you all for coming to this evening's symposium, and I think we have heard excellent overviews on this emerging topic, basically beyond BRCA, HRD, and you can see that this is a very quickly evolving field. There is actually an increasing role for PARP inhibitors, and therefore we need to start to know what tests to order. So I think one take-home message I would really like to give is that there are actually many different tests leading to PARP inhibitors in different indications. So you just need to look at them carefully. It's not a single test. So for different cancer type, it might be a different gene, a different test. It may be tumor, it may be germline, so they all have different implications. And in particular, if you're going to do germline testing, you do need to exercise some caution. If you can get access to genetic counseling, that will be good. If not, at least you should counsel the patient some of the implications of having a germline heritable information. So thank you all for coming and have a good night.